clinical cells lay. Good evening to one and all present here. So it's an immense pleasure to invite for the second Oxy Clinical Skills Hour on CTG, LCG and Partogram. I request moderators Jayashree Gajraj Madam and Dr. Deepa Tangamani Madam to start the session and request to introduce the presenter to go with the case presentation. Over to you, Deepa ma'am.
Yeah. Thank you, Meena. So it's my pleasure to have the second series of this LCG, Partogram, and CTG, Oxy Clinical Skill Hour. It's a 1 hour programs. We are doing it every month, last Tuesday. And today, from Vijaya Hospitals, Dr. Roshni is presenting a case. She's doing her second year at Vijaya Hospital. Her mentor is Dr. Niranjana. She's a senior consultant, OG Vijaya Hospitals. And over to you, Roshni. We start the presentations. 15 minutes.
Yes, ma'am. Yes, ma'am. Mrs. X, 25-year-old, primigravida, 39 plus 3 weeks gestation, wife of Mr. Y, resides at Poonamalli, educated up to BCom, and is a homemaker. She belongs to Class 2 Modified Kuppuswamy Socioeconomic Class. Her LMP was on 18/4/2024 with previous regular 30-day cycle. Her dates were reliable. EDD was on 23/1/2025. She is booked and immunized. Blood group is O positive. Next slide, ma'am.
Yeah, go ahead.
Presenting complaints. She presented with complaints of on and off pain abdomen for the past 10 hours, increased in intensity over the past 2 hours, that radiated to the lower back and thighs. There were no aggravating or relieving factors. She had complaints of leaking PV for the past 1 hour, perceiving fetal movements well. History of present pregnancy, coming on to the first trimester history. It was an ovulation induction conception with tablet letrozole 2.5 mg, and this was the first cycle. It was confirmed by urine pregnancy test at 40 days of amenorrhea. She was on folic acid supplements post confirmation of pregnancy only. Gestosis score calculated was 1. Viability scan showed a singleton intrauterine pregnancy corresponding to her LMP. First trimester investigations done at 6 weeks showed subclinical hypothyroidism, and hence she was started on tablet Thyronorm 75 micrograms. There was no history of hyperemesis gravidarum or fever with rash or bleeding PV or exposure to radiation or drug intake. The NT scan was said to be normal. Serum double markers were said to be at low risk, and dose of tablet Thyronorm was reduced to 50 micrograms at 12 weeks of gestation.
If I can just interrupt you for 1 minute here.
Yes, ma'am.
You said she was on folic acid supplementation post-pregnancy.
Yes, ma'am.
Right? She's a patient who's been under care, who has actually conceived with ovulation induction.
Yes, ma'am.
What is your comment on that?
Yes, ma'am. She must have been actually started on folic acid supplements at least 3 months prior to the conception, ma'am. But in her case, she was not regular on taking the supplements and she has taken it only post-conception, ma'am.
Okay, right.
To prevent neural tube defects, we need to actually start 3 months prior, ma'am.
Yeah, no, especially somebody who's already been on
ovulation induction.
Care, right? It's not just conceived and come. So you
yes,
would expect her. So is that correct? Is what I'm asking. Did
yes,
she not take?
She was not complaint actually, ma'am. She was advised to take, but only after confirmation she was again persuaded to take the drug, ma'am.
Okay, right. Yeah, go ahead.
Second trimester history. The number of antenatal visits in the second trimester were 2. Quickening was felt at 5th month of pregnancy. She was started on iron and calcium supplements. Anomaly scan was said to be normal with no gross anomalies. She was immunized with 2 doses of injection TD. GTT was done which showed elevated sugars. Hence, she was started on medical nutrition therapy. She was diagnosed to have mild anemia at 24 weeks, along with the GTT when it was done, and she was hence started on oral iron twice daily. Total weight gain in second trimester was 4 kg. She had complaints of swelling of both legs, which decreased on elevating the legs and resting. There was no history of decreased urine output, or blurring of vision, or epigastric pain. No history of bleeding PV was present in the second trimester.
Then again, here just one word.
Yes,
in the previous slide. So I think when you are presenting, should you be saying NT scan said to be normal? Is it because she does not have the report with her, or is it
Ma'am,
what
because
was
we are not supposed to be accessing the records, ma'am, when we are presenting a case. That's why I mentioned said to be, ma'am.
so it's purely by complaints?
Yes, ma'am. Based on patient history, ma'am.
Okay, so similarly for the GTT also.
Yes, ma'am.
Okay, and now this 2 doses of TD that you're talking about, you think that is that the recommendation, or what is the
It's
recommendation for a
actually,
tetanus immunization in pregnancy?
yes, ma'am. It's supposed to be 1 dose of injection TD at the first trimester around 13 weeks, ma'am. And second dose should be a TDAP, ma'am, at 28 to 29 weeks.
Okay, why is the first one given at 13 weeks, and why is the second one given at 30 weeks? Is there any rationale?
It's to cover it's to cover the fetus till the delivery, ma'am. The TDAP
So
is given
after
at around
delivery,
20.
when will the child develop pertussis? After delivery or before delivery?
After, ma'am.
So you said till delivery it will cover.
Sorry, ma'am. I meant
How
post
often?
delivery till the.
How often do you see an antenatal mother having tetanus? How often was neonatal tetanus once upon a time reported? What is the
Um, I'm not sure, ma'am.
okay? So do we have neonatal tetanus nowadays in our country?
No, ma'am.
We don't. Then why are we immunizing?
Um,
Okay, so basically the rationale of immunization, see, once upon a time, they used to finish both the doses even by 13 weeks. And you find still there is a practice where both doses, tetanus toxoid is actually given. Okay, now we know TD is what is recognized even by the government of Tamil Nadu. So TD is what is given. And it is the rationale is not only to cover the mother, usually mother is covered for tetanus even before, because you know that in single injection of tetanus toxoid taken for any other reason prior to pregnancy, the coverage is actually for how many years?
5 years, ma'am.
Even longer. Okay, so most
10,
moms, yeah, 10 is the
10 years.
antibody, reliable antibody levels. So normally, actually speaking, the mom doesn't really need a coverage. So they realized that there was no point giving it too early. The titers were falling towards term and immediately after also. So it's more to cover the neonate. So that's the rationale for giving it at a later date. And we know pertussis, again, many neonates they don't have the antibodies. So therefore, Tdap is given in the third trimester. Okay. So just look up the immunization schedule by WHO. You should be thorough with it.
Okay, ma'am.
Why we are giving, when we are giving.
Okay, ma'am.
Yeah, okay, go ahead.
Third trimester, number of antenatal visits in the third trimester were 5. The sugars were monitored serially, and it was said to be controlled with diabetic diet. There was history of swelling of both feet, which decreased on rest. No history of decreased urine output or blurring of vision or epigastric pain. She was perceiving fetal movements well. She continued to take iron and calcium supplements regularly. No history of bleeding or leaking PV or pain abdomen or bowel bladder disturbances. Interval growth scan done at 28 weeks. Baby was said to be growing according to gestational age with estimated fetal weight of 1.2 kgs. The ECG and echo were said to be normal. Growth scan at 36 weeks showed cephalic presentation with estimated fetal weight of 2.5 kg with Liker normal. Total weight gain in pregnancy was 12 kg.
So again, when is the echo normally recommended? When is it done? And why is
Usually
it?
it's in the third trimester between 28 to 32 weeks, ma'am. That is because that is the time when maximum hemodynamic changes occurs, ma'am. So to rule out any cardiac dysfunction, we need to do it around that stage, ma'am.
And is there any assurance that if you have a normal echo, she will not develop any problems later on?
No, ma'am, we can't be very sure of that, ma'am. The maximum cardiac output increase is at labor, ma'am, and post partum also. So, but structural changes, structural anomalies can be ruled out, ma'am. With echo and
Structural anomalies in the mom or in the baby?
for the mother, ma'am.
Mother, okay, mother.
Mother.
Hopefully by now we would have found out.
Yes,
So,
ma'am.
okay. I think third trimester is too late to be finding out structural anomalies in the mother, right?
Chiefly the hemodynamic
Yes or no?
changes, ma'am, for that. Yes, ma'am. Yes, ma'am. It's late. Coming on to the menstrual history, menarche was at 13 years with regular 5 by 30-day cycle, moderate flow. There was no history of clots or dysmenorrhea. Her last menstrual period was on 18th of April 2024. Marital history, she has been married for the past 3 years at 22 years of age. It was a non consanguineous marriage. Past medical history, no history of diabetes mellitus, hypertension, tuberculosis, asthma, epilepsy, jaundice, thyroid disorders, or blood transfusion in the past. Past surgical history was nil. Personal history, she had a normal sleep and appetite, no history of substance abuse, no history of drug allergies. Diet history, she was a vegetarian by diet. I've mentioned the 24-hour dietary recall here. According to that, the total calorie intake was 1,495 kilocalorie with a deficit of 900 kilocalorie per day, and total protein intake was 68.4 grams with no deficit. Family history, no history of diabetes mellitus, hypertension, tuberculosis, multiple pregnancy, congenital anomalies, or preeclampsia in the family. I'll sum up the history. A 25-year-old Mrs. X, primigravida, 39 plus 3 weeks, ovulation induction conception, booked and immunized, with last menstrual period on 18/4/2024 and EDD on 23/1/2025, came with complaints of on and off pain abdomen for the past 10 hours, increased in intensity for the past 2 hours, radiating to the lower back, and complaints of bleeding PV, leaking PV for the past 1 hour. She was diagnosed to have subclinical hypothyroidism, mild anemia, and gestational diabetes mellitus on medical nutrition therapy in her regular antenatal investigations. Now admitted in labor.
Sorry, I
On
lost a connection in between. Go ahead, ma'am.
Yes, ma'am. Examination. General examination, she was moderately built and nourished. Her height was 146 centimeter. The weight at present is 69 kg. Pre-pregnancy weight was 57 kg. So BMI based on the pre-pregnancy weight was 26.7 kg per meter square. There were no spine deformities or abnormal gait. Vitals, temperature was 98°F. Pulse rate was 92 per minute. It was regular in rhythm and normal volume and character. All peripheral pulses were equally felt. The blood pressure was 110/70 millimeter of mercury measured in the right arm in sitting position with cuff at the level of the heart. Respiratory rate was 18 per minute. Thyroid and breast examination were normal. Systemic examination, cardiovascular system, first and second heart sounds were heard, no murmurs. Respiratory system, normal vesicular breath sounds were heard. Obstetric abdominal examination, on inspection, abdomen appeared longitudinally distended with flanks full. Umbilicus was flushed with the skin surface. Linea nigra and striae gravidarum were present. No scars or sinuses. No cough impulse present at the hernial orifices. Palpation, fundal height corresponds to term size. Symphysis of fundal height was 38 centimeter. Fundal grip, broad, soft, irregular, non-ballotable mass felt, which was suggestive of fetal breach. Lateral pelvic grip revealed a smooth, curved, uniform resistance, which was suggestive of fetal back, felt on the right side, and small, knobby, irregular parts, suggestive of limb butts, felt on the left side. First pelvic grip, there was a smooth, hard, globular mass felt, suggestive of fetal head, and it was 4/5 palpable. Second pelvic grip confirmed the findings of the first pelvic grip, and the head was confirmed to be well flexed. Fetal heart rate was 160 beats per minute. It was regular. It was heard on the right side in the spino-umbilical line. Uterine cavity, uterine activity, there were 3 contractions for 45 seconds over 10 minutes. Leica felt clinically adequate. Estimated fetal weight by Johnson's formula was 3.8 kgs. Coming on to the pelvic examination, inspection of external genitalia, it looked normal. Speculum examination, grade 3 meconium stained Leica was noted. Vaginal examination, cervix was soft, mid position, fully effaced, 5 to 6 centimeter dilated. Membranes were absent. Grade 3 meconium stained Leica, vertex at -3 station, grade 1 molding was present, and pelvis was adequate. Summarizing the case, a 25-year-old Mrs. X, primigravida, 39 plus 3 weeks, ovulation induction conception, booked and immunized with last menstrual period of 18/4/2024 and EDD of 23/1/2025, came with complaints of on and off pain abdomen for the past 10 hours, increased in severity for 2 hours, radiating to the lower back, and complaints of leaking PV for the past 1 hour, diagnosed to have subclinical hypothyroidism, mild anemia, and gestational diabetes mellitus on medical nutrition therapy in her regular antenatal investigations. On examination, uterus size corresponding to term size, acting 3 contractions for 45 seconds in 10 minutes. FHR was good, grade 3 meconium stained liquor, with PV showing cervix 5 to 6 centimeter dilated with fetal head at -3 station. So, provisional diagnosis, it's a 25-year-old primigravida, 39 plus 3 weeks of gestation, ovulation induction conception, GDM on MNT, mild anemia, subclinical hypothyroid, cephalic presentation, admitted in active labor with grade 3 meconium stain liquor.
Okay, so in your examination, you said it was
Yes,
a well
ma'am.
flexed head in your second
Yes,
pelvic
ma'am.
rib.
Yes,
Okay.
ma'am.
Can you explain that to me? How do you make out it's a well flexed head? What are your findings that will tell you it's a well flexed head or a deflexed head?
Yes, ma'am. It's based on the synciput and occiput's relation with respect to each other, ma'am. So, in a well flexed head, the occiput will be higher than the synciput, ma'am.
Are you correct?
Um,
So which is occiput, which is inciput now? In a well flexed head, where you're going to go down like
occiput
this.
is higher. Occiput is higher, ma'am. Sorry.
Okay. Think again. No, I'm confused. So as you are palpating, suppose
Yes,
you can feel both occiput and sinciput. What is it suggestive of?
deflexed, ma'am.
Okay. So now as it flexes, what will go down into the pelvis? What will come up?
The synciput goes down, ma'am, and occiput comes up.
Epidima.
Uh,
This is occiput, right?
yes, ma'am. Yes, ma'am.
It's sinciput. So
Yes,
unless it's
ma'am.
good like that, okay, we'll ask Deepa for clarity. You're muted, I think, Deepa.
She is confused only. Okay, in well flexed head, we can see only the sinciput up and we cannot feel the occiput. Correct?
Yes, ma'am.
Occiput will go into the pelvis, isn't it?
Pelvis. Yes, ma'am. Okay.
The sinciput will come up. So
Mm.
that's why I
Okay, ma'am.
asked you the earlier stage. If you can feel both, what does it mean? So it means it's a deflexed head. You quite
Deflexed
rightly
head.
said.
Yes, ma'am.
So once it starts flexing, the occiput will go down and the sinciput will come up. Right. If the occiput comes up and sinciput goes down, what presentation is it likely to become? Like
Face presentation, ma'am.
face or even brow sometimes. Yeah.
Bro. Yes. Yes,
Basically,
ma'am.
it's going to go up this way. Okay. Right. Fine. So you know the importance of the grips. It's very important. Not just to pull out and say, hey, this is mobile and get on with it. We should make every attempt to go ahead with it. Yeah, fine. And can you tell me a little bit more about anemia? What are the
Ma'am, this
cutoffs?
was
How do you diagnose anemia?
yes, ma'am. Cutoff for the first and third trimester, it's 11 gram per deciliter, ma'am. And for the second trimester, it's 10.5 gram per deciliter. And we also have severity grades, ma'am. The WHO and the ICMR severity grades. So mild anemia is from 10 to 10.9, ma'am, according to WHO. The
Right.
moderate is 7 to 9.9, ma'am. And severe is less than 7. ICMR also has a very severe grade, which is less than 4, ma'am.
Okay, so for all this, there is one qualifying statement, no, to end it with. What is that? Where should the woman live?
Sorry, ma'am.
Where should the woman live? If she lives on Mount Everest, it's the same values. If she lives in Chennai, is it same values?
Not
I
sure,
think.
ma'am.
So these values are meant for sea level. Okay.
Okay, ma'am.
Right. So you look up the definition once more. The WHO will
Okay, ma'am.
always qualify it by saying at sea level. And that's
Okay.
important. Why do you think it's important? What
The
happens
oxygen saturation that will be decreased at the mountain levels, ma'am. Higher altitudes. So
So what values do you think will be more correct? Okay, I'll give that to you as homework. Okay.
okay, ma'am.
Right. Okay. Right. Yeah, go ahead now. Sorry. Deepa, is there anything else in the history you want to ask her? History findings?
Fine, madam. Okay. Can you sum up what are the high? I think I'm audible, right? Okay.
Yes, ma'am.
Roshni, can you sum up? So this is the patient. You are in the labor ward. You are seeing her. So quickly go through what is the risk factors. You rather than all those things, what is the risk
Yes,
factor? Or common risk factors. You'll keep it in the mind and then see then what next you will do.
yes, ma'am.
Hmm. Tell me what are the risk
Uh,
factors for her?
GDM on MNT, ma'am. OI conception, GDM on MNT.
Is it
Um,
late conception is a risk factor?
uh,
No.
it's a precious pregnancy kind of, ma'am. So
Why? Nothing.
Why?
OH.
Even if I conceive normally, my baby is precious for me.
yes, ma'am. Yes, ma'am.
Huh. So then if I have to take, then I'll take letrozole and make my baby precious.
Hmm.
So you won't take more care of my baby then?
Ma'am, we will take care, ma'am.
Okay, so no, I think the point we're trying to make is that word precious pregnancy has to slowly fade out, that term.
Okay,
Okay,
ma'am.
right. Then now go ahead. Go ahead.
So first of all,
Um,
start with the primary, start with next with the gestational age.
yes, ma'am.
Then her, well, you have written how many hours she is in labor and she is
Labor, yes, ma'am.
GDM. Then comes your
Yeah.
GDM, anemia, hypothyroid. So these are the risk factors. And
Yes,
clinical
ma'am.
examinations, your grade 3 meconiums.
Meconium, yes, ma'am.
Okay, she is in labor and she is in active labor and she is in grade 3 meconium. So these are the risk factors. So what could
Yes,
be the
ma'am.
reason for grade 3 meconium? Just without seeing her with this history, what could be the reason for her meconium? Are you concerned about grade 3 meconium? And if you are
Yes, ma'am.
concerned, what will be the why it is? What is among these risk factors which is causing the meconium?
GDM, ma'am.
Okay, why GDM?
Uh, Hypoxia to the fetus risk is there, ma'am, with
Why?
GDM. There will be increased oxygen demand, and that is not met, ma'am.
Okay. Increase
I
of
thought you told us that it was well controlled with MNT.
Yes, ma'am. Yes, ma'am. It is well controlled.
So does that equal her to a normal person, or does she still have all the risks of GDM?
She's still at a higher risk than a normal pregnant woman, ma'am.
yes, yes.
Okay. And that's what
Correct.
he's asking you. So why? What is it? You have to
So
tell
there
us
will
why.
be a relative uteroplacental deficiencies because though sometimes the baby will be big or polyhydramnios and there will be a edematous placenta because of the gestational diabetic changes. So that's one thing. Is it anemia is a risk factor for her?
Yes, ma'am. It was mild anemia, but still it's a risk factor, ma'am.
Okay. So how it affects how it causes hypoxia or causes distress for the baby?
Oxygen carrying in the mother per se is less, ma'am. So the transfer to the baby will also decrease.
So how she behaves, like she'll be more fatigued, she could not able to, so someone who has with good reserve, have gone through the labor of 10 to 18 hours labors, but these patients with being an anemia cannot go through that because the stamina level may not be great. So
Yes, ma'am.
hypothyroid, what about the subclinical hypothyroid? What does it
Subclinical
cause?
has, uh,
Is it risk factors or not?
it is, ma'am.
How?
Uh,
How was
Not
it,
sure,
Alice?
ma'am.
Not sure. Then why you are
Not sure.
telling? Okay. See, so most of the times hypothyroid may not have a good progress of labor. That is the only thing, but it is only a theoretical. So not applying correctly on that. I think it's correct. So another risk factors here is her history suggestive of 10 hours of labor. So
Labor, yes,
we
ma'am.
don't know how many hours of really good labor she has. So that is one reason. Okay. So when it comes to a mind, it's only primary is a risk and she is in at the near term. And meconium, the cause for meconium could be all those things. Most important is like long labor with the gestational diabetes is the first cause, and she couldn't able to cope up with because there is no pain score in your presentation when she came in labor. Correct? How she
Yes, ma'am. Yes, ma'am.
she is shouting, how she cope up, because already she is in active labor when she comes. That means she has gone almost some hours of labor without any painkillers at home, right?
Yes, ma'am.
Okay, so it's either way, whether she has a good pain control or she doesn't have a good pain threshold.
Um, I'm sorry, ma'am.
If she have a good pain threshold, because say once everyone have a labor pain, they'll come to the hospital.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Once you have a back pain and radiating to the back, abdomen pain radiating to the back, it's a sign of labor. And if it comes
Yes.
regular, you have to come to the hospital. But she
Yes, ma'am. Yes, ma'am.
5 to 6 centimeter dilatations. Okay, so that is
Yes,
why.
ma'am.
Okay, is it a risk factors, the labor pain?
Yes, ma'am. Prolonged labor pains. So that's also without monitoring.
Without monitoring. Oh, okay. Without monitoring is a risk factors, yes. So with this background, you admitted her, she has a leaking, you did a speculum examinations, you are putting a CTG. Side by side, did you do any investigations?
We sent for CBC CRP, ma'am,
Where
and
does
urine routine culture also, and high vaginal swab we had taken, ma'am.
why
And
high
sugars, ma'am. Sorry, ma'am.
why high vaginal swab?
That is to check for any streptococcal organism growth, ma'am.
Why streptococcus?
To rule out chorioamnionitis, ma'am.
Okay. So by the time the culture will come, we will make a decision. So what effect it is going to give us? It's a term PROM and she's already in 5 to 6 centimeters.
Do you really expect? Do you really expect Group B strep in this situation, and is it going to help your management at the moment?
No, ma'am. No, ma'am. At the present, we need to start her on empirical antibiotics, ma'am.
Yes.
Postnatally,
Okay, you did a CBC, and then second thing is like you did a
CRP,
CRP.
CRP.
Get the values back.
Values by the time it came, we had finished the LSCS, ma'am.
Okay, okay. So now explain the CTG.
Okay, ma'am. The baseline heart rate is 160 beats per minute, ma'am, with a variability of around 10 beats per minute. There are no accelerations seen, and multiple early decelerations are seen, ma'am, up to 100 beats per minute, ma'am.
Okay, so whenever you explain the CTGs, it is better
Con-
to use Dr. C. Bravado score. Okay, so you
yes,
start with
ma'am.
what are the things I told? Define risk. So
Yes,
here,
ma'am.
the case of
It's a
primary pregnancy,
primigravida,
here what?
39 plus 3 weeks, came with labor pains for 10 hours and leaking for 1 hour. And she has grade 3 meconium stain like ma'am.
And then C, contractions.
Yes, ma'am. Contractions are strong, ma'am.
How many
Up
Is that the
contractions?
way
to,
to describe
there
contractions?
are 4 contractions, ma'am.
You have to tell us, no, in a more scientific manner. There's no point in strong contractions.
It's up to 40 seconds, ma'am. Around 40 seconds.
You yourself has written in that you have 3 contraction in 10 minutes, each contraction lasting for 40 to 60 seconds, right?
Yes, ma'am.
Okay, so that is how you have to describe a CTG. Whenever you have a CTG, this is a 20 minutes trace of CTGs, and this is belongs to the patient so and so. She is a primary Her risk factors is she is a primary 39 weeks, PROM for 1 hour, and grade 3, grade 2 meconium strain like
Like
contraction. She is getting 3 contractions. Then comes the baseline rate, 160 beats per minute. This 160 beats per minute for the gestational age of 39 weeks is a normal or not?
it's up to 160 is actually 110 to 160 is normal, ma'am. This is borderline.
There is nothing like borderline. It's normal or
It's
abnormal.
normal, ma'am.
There is in a nice guideline, if you see, it is 160, 110 to 160, it's okay, normal. But there is also, you have to apply physiologically. For a patient with 39, 40 weeks, the baseline heart rate cannot be 160 beats per minute because the vagal maturity will be started. So it will be fully developed autonomic nervous systems. So the baseline heart rate expected in 38, 39, 40 weeks is around 140, 130 to 140 beats, not 160 beats per minute.
Okay,
Can I
ma'am.
request the others to just mute themselves, ma, please, apart from the 3 of us?
Okay.
Thank you.
Dr.
Yeah, go
Tabassum,
ahead.
can you please mute your mic, Tabassum?
Yeah, go ahead. Go ahead.
Okay,
Thank you. Thank you.
baseline heart rate for 39 weeker is 160. I would call this as a fetal tachycardia.
Tachycardia. Okay, ma'am.
Okay. So
Okay,
now
ma'am.
the variability. Your variability you said is absolutely fine. Second thing is decelerations. Okay, so what
Yes.
type of deceleration you said? Early deceleration.
Early deceleration, ma'am.
Why you said early deceleration? What is the definition of early decelerations?
It coincide with the onset coincides with the onset of contraction. Nadir coincides with the nadir, and
No,
the
when I draw, it is not coinciding.
Probably you're not drawing correctly.
Okay, but it has to be uniform. All the deceleration has to be uniform mirror image. That is, somewhere it is not. See, this is a broad deceleration, I
yes,
would say. So,
yes,
the really deceleration cannot be broad like this. Okay.
okay, ma'am.
It's not an early deceleration. It takes some times to come back to the normal.
Okay, ma'am.
Okay, so this is not a early decelerations. So where does early decelerations happens?
In head compression, ma'am.
Okay, is it normal or not?
It is normal, ma'am. Usually, when the head descends, you can have early decelerations, ma'am.
Yeah, according to
Why
you,
is it normal? What is
Ma'am,
the what is the
the
physiology behind it?
ma'am, the dural there is compression of the meninges, ma'am. Uh, so
Therefore,
uh, there will be suppression of the sympathetic system, and therefore the parasympathetic activity is increased. So there is slowing down of the fetal heart rate.
okay. Sorry, I interrupted Deepa. Go ahead.
no problem. So, so early decelerations, your baseline heart rate, if you say it is normal, your early deceleration is also a normal. So this
Normal.
CPT, according to you, is an absolutely normal. Correct?
Yes, ma'am.
Okay, but I'm because of only grade 2 meconium stain like us, you have taken up the cesarean sections.
Yes, ma'am.
Okay, and your outcome Apgar is absolutely fine.
Fine. Yes, ma'am.
So why did you stop? See, because then why did you do a cesarean sections only for grade 2 meconium stain like a?
And grade 1 molding, ma'am. But that's also again it's acceptable, ma'am. Grade 3 meconium actually, ma'am. Here it's labeled wrongly as grade 2. It was grade 3 meconium stain like a.
That's what you presented.
Okay.
So
Yes, ma'am.
8 to 9 centimeters.
Sorry, ma'am.
8 to 9 centimeters.
5 to 6, ma'am.
5 to 6. Okay.
5 to 6 centimeters, vertices -3. Clinically is well flexed.
Yes, ma'am.
Okay, and -3 stations with no caput with a grade 1 molding and grade 3 meconium stain like a.
Yes, ma'am.
Okay, so that's fine. So now would you like to change? Because I said the baseline nitrate is not appropriate for gestational age.
Yes,
And this
ma'am.
deceleration, what I am noticing is not
Variable.
not a early decelerations. It's a broad, somewhere it's broad deceleration, somewhere it's okay, and somewhere it's a sharp decelerations. Okay, so and it is not repetitive. We have 4-5 contractions. Any contraction which
Yes.
is repetitive, each and every deceleration which is repetitive, each and every contractions only we will be doing it. So what you would have done? I said it's a suspicious CTGs because that
Yes, ma'am.
is baseline heart rate, some variable decelerations without any complicating factors except one broad deceleration, because broad deceleration, if it is comes every contractions or every other 50% of contractions only, we have to worry.
Yes, ma'am. So intrapartum resuscitation could be done for her, ma'am. Left lateral position, oxygen, IV fluids.
Okay. Did you stop the
And
CTG at this times? Because your CTG has been stopped at this time.
yes, ma'am, we stopped, ma'am. We took up for LSEs after the CTG, ma'am.
Okay, now let's think that you have not taken this lady up. You have not done a cesarean. Okay. So let's just
Yes,
come
ma'am.
back to this position. Now tell us. Forget what you did was a cesarean. Forget about that. You are managing the labor at this point. That's what Deepa is asking you. What would you have done now?
I would
If
have
you had not
tried intrapartum.
resuscitated,
Intrapartum resuscitation, I would have tried, ma'am, and repeat CTG for another 20 minutes.
Not
If it is still
CTG. You cannot discontinue the CTG. You have to continue the CTG.
continue, yes, ma'am.
so repeat CTG is not the right word to use.
Continue CTG for another 20 minutes, ma'am.
Yeah. Okay.
So what are the
But
results?
considering grade 3 MSL,
Okay.
that's why we took up for LSEs, ma'am.
Why? Considering grade 3 MSLs, what other factors worried you? If it
And
is
GDM,
second Travida, if suppose
GDM, ma'am.
second Travida,
1900.
multi-previous normal delivery,
Multi, we
190.
could have waited if she was at 5 to 6 centimeters. We could have waited, ma'am. Primary with the vertex at -3 station and 5 to 6 centimeters. We can't like give that time, ma'am. It will take some time for her to progress, around 3 to 4 hours.
all are assumptions, right?
Yes, ma'am. Yes, ma'am.
Because we have seen only for 1 hour. So active management, what you would have dependence. Only thing is your worried is a grade 3 MSL, correct?
Yes, ma'am. Yes, ma'am.
So, what will happen? Grade 3 MSLs with suspicious CTGs, since the labor is, you're justified, since the labor is going to be more prolonged for a multi because it's -3 station, and already at -3 station, there is future suggestive of,
Molding also, ma'am.
what does it suggest?
Cephalopelvic disproportion.
Okay. So that is the reasons you are justified in taking it. Okay. But so the reading of CTGs, what do you find this reading of CTGs? The baseline tachycardia.
Yes, ma'am.
So baseline tachycardia with some kind of variable decelerations, you will resuscitate. You look for the fever, temperatures and other things. Absolutely, your mother doesn't have fever and temperature.
Yes, ma'am.
Or it could be the second possibility reason is, one is clinical, subclinical chorioamnionitis for the baby, which is causing meconium and fetal bradycardia, and ongoing hypoxia.
Yes, ma'am.
Done? Okay. Madam, anything to you add on? Okay.
Yeah, no, nothing.
Now explain the partogram.
Okay, ma'am. Again, I'll start with Primey, ma'am. She's Primey 39 plus 3 weeks with risk factors GDM on MNT, subclinical hypothyroid, and mild anemia. This was a spontaneous labor, ma'am. And the first stage lasted for 10 hours. So here the baseline heart rate is around 160 beats per minute, ma'am. And she was 5 to 6 centimeters dilated, ma'am. So I've marked as 6 centimeters, ma'am, on the alert line. And the contractions were effective, ma'am, around 40 seconds. So I've shaded it with dark shading. And I've marked the grade 3 meconium stain Leica. And grade 1 molding is also present, ma'am. And maternal vitals were normal, pulse, temperature, and BP.
So, what are you mentioning about first stage 10 hours, ma?
Ma'am, actually, first stage is still not over, but so far 10 hours. That's what I want to tell, ma'am. First stage, it's not still over, so we actually can't comment on that.
So that's the answer
Yes,
I
ma'am.
wanted, because it's
Yes,
not
ma'am.
documented. Okay, it's a
Yes, ma'am.
Partogram is a documented, so it's a fresh. It is a prospective documented. After she comes to you, only the documentation starts.
Yes, ma'am.
Okay, so
Yes, ma'am.
first stage is it's just an assumption. As per the history, we are putting it.
Yes, ma'am.
Okay, the same assumption only you put this 6 centimeter dilatation in the active line, alert line, right?
Yes, ma'am. I mean, the first reading, we usually put it on the alert line, ma'am. After 4 centimeters dilatation, it's marked on the alert line as the baseline for monitoring the labor, ma'am.
But by putting that at the alert line, the previously you are telling that 2 hours before she must be in 4 centimeter.
Um,
Retrospectively, you are telling us that she will be 4 centimeter or 6 centimeters or she could be anything.
we are not actually commenting on that, ma'am. Like, I've marked the 6 centimeter on the alert line, ma'am, because we conventionally plot whatever value it is on the alert line, ma'am.
Madam, do you want to comment on it? Okay, see what I say is like traditionally it was mentioned that it 4 centimeters at the alert line. That is what this line has come. But what our LCG guidelines are the six, it is a prospective, it's a 0 hours you have to start. So whatever the
Okay, ma'am.
documentations it is actually a documentation. If you put at 8:30 means 0 hours she was with you.
Yes, ma'am. Yes, ma'am.
So indirectly, but you have she was with us only 8:30 a.m. So
Yes, ma'am.
assuming the previous 0 hours, 1 hour, she is with us and we are documenting. It's a legal document.
Yes, ma'am.
So that is the reasons. Maybe though the teaching is on the to be put on the alert line, but it has to be done on the 0 hours is an ideal way.
0 hours.
So it is a dynamic thing and it is a prospective thing.
Okay, ma'am.
So you are seeing even you have other parameters. We are not showing only the 6 centimeters here. So the
Yes, ma'am.
documentation 0 hours, if you put it, you have the position, you have contractions, you have molding. So at 0 hours in the hospital, when you see her at 6 centimeters, 5 to 6
Yes,
centimeters.
ma'am.
Okay, so that is how the documentation has to be there. It's legally I felt recent WLCG as well as the teaching previously also the WHO Partogram also says 0 hours will be the thing freshly at when
Starting.
you see the patients. When
Okay,
you
ma'am.
see the patients, that is what.
Okay, ma'am.
Okay, so that is an ideal thing. So if you put 6 centimeters here, so what happens? She might be same 6 centimeters at 0 hours also.
Yes, ma'am.
Cannot assume anything, but you have put a 0 hours, you put marked a fetal heart rate. This is what will happen. So even she is not with us, we'll try to mark in 0 hours, 1 hours. When she is not 8:30, only has to be there in the 0 hours.
Okay, ma'am.
Okay, so that is most important. That is what I want to discuss about thing, madam.
Yeah, I think, see, by marking this, you're actually asking for trouble.
Okay, ma'am.
Okay. I think you
Okay,
need
ma'am.
not have put a partogram at all then. That would have been better.
Correct.
So you need to follow all the components and you need to start marking. So what
Yes,
made you
yes,
mark
ma'am.
only here? You tell us that.
Sorry, ma'am.
What made you start mark only the 6 centimeter?
Ma'am, because we don't know the previous readings, ma'am. When she came to us, she was straight away 5 to 6 centimeters, ma'am. So,
And you took her up immediately.
yes, ma'am.
Okay. So why partogram then?
Um,
Am I being difficult?
yes. No, ma'am.
For the case discussion purposes, she put the partogram.
Okay. Then
might-
I'm asking
She might be
practically.
started, but she must be started maybe after that 8:30. She must have started because the end result she must not have written. She has not done a PV after 9:30, 9:30. Correct? You are
Yes,
not
ma'am.
at the PV at all. So then after that, she has taken up immediately.
Yes, ma'am.
See the confusion you see. You mentioned at 2 hours at 8:30, but you all your markings has been done on 0 hours 1 hour. That is what happens. But actually, it has
Yes.
to be after 8:30.
After. Yes, ma'am.
Okay, so that is why
So
you have to shift your 8:30 over there and shift your 6 centimeters at 0 hours.
Universe.
So we are
yes,
not
ma'am.
free
Yes,
about
ma'am.
anything, whether because we have not seen the patients. Before that, whatever happened, I don't know. I have to plot at 0 hours when I am seeing her.
Yes, ma'am.
Okay.
That's
Yes,
all.
ma'am.
There's
I'll
nothing
send
for
it.
it. No need to do the rest of it at all. What we are doing, what we see, you just mark.
Okay, ma'am.
Okay. Suppose, so you missed 10 hours of active labors because
Yes,
you
ma'am.
operate the labor. So
Yes,
whatever
ma'am.
the labor is probably active labor or prolonged latent phase converted to the active labor. If you seen her on that time, what would you have done? What best you could have done? Whether you avoided cesarean sections, you could have done anything.
Ma'am, I don't understand the question, ma'am.
See,
Sorry, ma'am.
we missed our 10 hours of journey of labor.
Yes, ma'am. Yes,
So
ma'am.
suppose if she comes little early, so what else you have done it better?
Uh, with the leaking with the same grade 3 meconium and everything, ma'am.
Oh no, before that, see, we missed our 10 hours of labor. We use
Okay,
only
okay,
5
ma'am.
to 6 centimeters, 10 hours, and the decision has been done. You justified there is a suspicious ETGs. After I mentioned it is a fetal tachycardia. Okay, so fetal tachycardia with grade 3 meconium. Grade 3 meconium without any CTGs, would you do C-section is a different question. So I would not have done it without any
Yes, ma'am.
abnormality. Probably I will given a chance because I am seeing her only 6 centimeters. Probably she must have 2 centimeters 2 hours before.
Yes,
All are assumptions. Okay, if
yes, ma'am.
CTG is normal, I would have been waited. I will continue the CTGs.
Okay,
I will
ma'am.
see, at least I will see the progress of labor, how fast she is making because she is getting 3 good contractions.
Yes, ma'am.
Since there is a baseline tachycardia, it's the baseline which is not appropriate for gestational age. Probably that maybe if we continue, if even after resuscitation, same thing, then probably we'll ended up having C-section.
Yes, ma'am.
Okay, so
Yes,
if
ma'am.
you see her before whatever it is, forget about that 10 hours, 5 hours before you see her. So what did you do?
Um, I would have augmented the labor, ma'am.
Mm.
Like if she had pains, I would have augmented the labor and
Mm.
assessed periodically, ma'am.
Okay, so you would have caught her, you have monitored her labor. First and foremost things, she had unmonitored labor.
Yes, ma'am.
So you would have monitored her labor by doing a CTGs. She is
CTG. Yes, ma'am.
If she is a 4 centimeter, she comes into the active phase. So you would have put a continuous CTG or intermittent CTG or only intermittent auscultation. Try me.
Continuous CTG, ma'am.
Why?
Because she's an active phase, ma'am, and she's also a GDM, ma'am.
Correct. She is having a high risk factors. Among the high risk, GDM holds higher point. So you were actively monitored. You have given supportive measures.
Yes, ma'am.
Okay, you are given a birth companions, you have position at all look at the LCG guidelines. So you have given a supportive measures. You have told her if she is in a vague pain for a longer time, you are given even
Pain control.
dural or pain controls, position
Yes,
change,
ma'am.
all those things. So all those things would have changed the whole scenario.
Yes, ma'am.
Okay.
Yes, ma'am.
Hmm? So that is also, then you would have done, if it is a protracted labor for a longer time, in a partogram, it comes beyond the alert line, then you would have done.
Augmentation, ma'am, to hasten the process.
Hmm.
And if it reaches the action line, then we have to take the decision, ma'am.
Hello.
Okay. So augment the labor. Is there any difference between LCG guideline, guide and partogram?
Yes, ma'am. In LCG, we start plotting only at 5 centimeters, ma'am.
No, regarding augmentations.
Regarding augmentations, ma'am, there is no fixed 1 centimeter per hour for LCG, ma'am. It's
Hmm.
individualized.
Hmm. So it is a dynamic. It is not a time
There
slot.
is no alert and action line.
Mhm. So how does it differs? So suppose if it is a 4 centimeters stays for a long 6 centimeters, starts at 5 centimeters, 5 centimeters stays for more than 6 hours only, alert comes.
It's
This alert
yes,
is
ma'am.
there. Alert is there for supportive care. Each section there is an alert line is there.
Yes, ma'am.
Remember that. Each section there is one alert line is there.
Alert line. Yes,
Okay.
ma'am.
Supportive care. If there is no birth companion, that is an alert. Then you have to
Yes, ma'am.
that. So same things. Okay, same thing for the progress of labor also, there is an alert line is there. For
Yes, ma'am.
Morphine alert line, for meconium alert line is there. Depending
Yes,
upon
ma'am.
grade 3. Grade 1 and 2 is different, grade 3 is different. So even if
Yes,
you
ma'am.
either of this, probably at this stage is different. If you see her little earlier, the problem must have been better. Maybe thin meconium would have been worried. 5 centimeters, you did a ARM augmented thin meconium.
No, ma'am. We could have waited, ma'am, with thin meconium.
Okay. Will you start if there is a poor progress thin meconium? Will you start oxytocin?
Yes, ma'am. We can start oxytocin. Judiciously, it has to be used, ma'am.
What is judicious?
Ma'am, we don't overdo the oxytocin, ma'am. We need to monitor the contraction strictly. 3 contractions for 40 to 45 seconds over 10 minutes is the goal, ma'am. So we need to titrate accordingly, ma'am.
So when you're answering, you need to tell us. I will put so many units of syntocinon in so many ml, and this is the dose at which I will give. So no using judicious terms.
Okay,
Yes,
ma'am.
you are giving room for to be asked more questions. If
Yes,
you
ma'am.
straight in one sentence tell us, I mean, will you put 1 unit syntocinon in 500 ml or 5 units or 10 units?
5 units syntocin and 500.
Yeah, so when you're giving the answer, try to factor all those things. So the examiner doesn't have any chance to ask you next.
Yes,
Okay.
ma'am.
Don't mask yourself in these terms.
Okay, ma'am.
So you try to tell us what is the correct dosage at which to start, how often I will try to increase it at this, every half an hour. So you have to bring out in 1 or 2 sentences, you inform the examiner that you know everything.
Okay, ma'am.
Okay. Right. Yeah.
Just
Just practice that.
I will just see whatever we discussed, we'll put it in for audience sakes. So this is your outcome. LSS for fetal distress. Fetal distress is because of the thick meconium licus, persistent bradycardia if continues. That comes under the amber color suspicious CTGs. So these 2 reasons you have done it. An average size babies, but she is short. I think it's 149 centimeters.
Yes, ma'am. 149 centimeters, ma'am.
Or it may be some kind of cephalopelvic disproportions in the form of molding. Okay.
Yes,
So you
ma'am.
are justified in doing a cesarean section in 1 hour. Okay. That is everyone will accept. Okay. So this is how your CTG, your traditional partogram. So where your traditional partograms, this is the modified partograms in your teaching place. That is what, this is the modified partogram you are using it.
Yes, ma'am.
So
Yes, ma'am.
where you will use the begin plotting at the 0 hour and the partogram. That is all the WHO says 0 hour on the partogram. Just because he has mentioned the active phase 4 centimeter on alert line, we assume that we can put a 6 centimeter also on the alert line. So that assumption should not be there. That is a one word given in WHO partogram. That is why the old teaching and most of the teaching institute is putting a 6 centimeter in alert line. The thing we are missing is the 0 hours. 0 hours is the documented things. Okay. So that is
Yes, ma'am.
how you have to do it. See, that is why. So if you put, this is 8 centimeter, here 4 centimeters and 6 centimeters, and every 2 hours I'm seeing 4th hourly I'm having 5 centimeters. But it may not be 4 centimeters before that, 2 hours before that. It may be
Yes, ma'am.
3 centimeter, 2 centimeter also. So that was the reasons. Without proof, any don't document.
Okay,
Okay.
ma'am.
That's what. This and all we have discussed. So it is a track of progress. It's only a prospectively. Only timely
Yes,
intervention,
ma'am.
not to back calculate. Road retroplat should not be done. So if she presented 6 centimeters, put it 1 centimeters. We don't have a vaginal examination at 4 centimeters. So there is no in-hospital monitoring before 8:30 a.m. So this will
Yes, ma'am.
definitely misleading and lead to underestimation of time in labor.
Yes, ma'am.
Okay, so that was the reasons. You may falsely think the labor is progressing fine, but
Yes,
actually
ma'am.
it's not. So that is the reason. Now, if you put the same case of yours in LCG, so if she comes thick meconium, suspicious CTGs, and fetal movement present, rupture for 1 hour, no fever, heart rate. So supportive care. So even the birth companion not there, it is an alert. Hydration
Yes.
not maintained. These are the things we missed in this case because she came late to the hospitals. Pain relief, if
Yes, ma'am.
offered, probably the baby would not have been stressed so much. Emotional supports. So that part. And this part is one, sorry, I mentioned is 170, it's 160. Okay.
160.
Deceleration is present, but it is a variable deceleration and CTG variability is fine. So what about the pain? Pain scores we don't have and coping mechanism of the patient is also we don't know. But by then we decided, so we cannot decide. And so no further cervical change. So 9:30, we don't mark anything. We have decided a 6 centimeter 8:30 itself after 9 o'clock itself. Once the CTG has been done. Okay. So LCG as you said, labor care guidance, there is alert is there, but it depends upon individual patients differently. Its alert is there for everywhere, but not alert line or action line. So coming to the CTG, as I said, these are the when you have say suppose you don't have the patients, only the CTG you are receiving. This is for a 39 weeker, it's a baseline tachycardia. Then why things has to go? It is because of JDM, it's because of anemia, or it's because of fetal PROM. Is it because of hypoxia? So all those things you have to run in the mind. So whenever you have a tachycardia, again, there is a Dr. C. Brivada score you have to do. We have to see what are the possible. So in tachycardia, the step-based management is BCOM approach rather than Brivada. So baseline is elevated. Is it transient or persistent? Is the environment? Environment is the womb. Okay. Is it liquor is there? Is it very hot and dry labor? Or that means in an obstructed labor. Is the temperature is there? So any maternal in C is for cytokines. That is why you are done a CRP. So is the baby movement is good. Loss of variability is a L. Loss of variability in tachycardia is a more significant rather than decelerations. As long as variability is there, that's good. Okay. So and monitor the interface and maternal factors. So this is another case of CTG. Can you read the CTG? C is a 1 weeker induction of labor thick MSL 3 centimeter.
The baseline is one
Sorry.
not clear.
This is 120. This is 100. This is 100. This is 120. This is 140. This is 160.
Uh,
Somewhere around
140, ma'am.
140. The line is 140 is here. Sorry, my line is 140 is exactly here. It is above 140.
Yes, ma'am.
So it's between 140 and 160. It's
140 and 150 beats per minute, ma'am.
150 beats per
She's
minute.
written
So,
150 there. So,
okay. So it's a 41 weeker. 150 is okay or not?
It is increased, ma'am. Tachycardia, ma'am.
Tachycardia. Okay. And there is a prolonged decelerations. Same
Yes,
kind of
ma'am.
these 3 centimeters meconiums in prolonged. There is something called, there is hyperactive variability. Is it okay?
No, ma'am.
Okay. What is it called?
Um, More than 25. Uh, Zigzag pattern, ma'am.
It's not more than 25. It's between 20 to 25. It is called
25
zigzag pattern.
zigzag
Okay.
pattern.
Zigzag pattern. Zigzag pattern is increases. This is baby is autonomic instability. Nervous system is unstable.
Yes,
So
ma'am.
41 weeks when you will you induce the labor with thick MSL 3 centimeter with kind of CTG?
No, ma'am.
Okay. So 150, 3 centimeters zigzag pattern, and there is
And
also
prolonged deceleration.
decelerations. All those things favor. This is not a good CTG. Okay. So
Yes,
can you
ma'am.
read this CTG?
Baseline is
40 weeks,
one.
140. Baseline is
Yes, ma'am.
140. 40 weeks.
140.
Hmm.
Variability is around 5 to 10, around 10 beats per minute, ma'am. And accelerations are present. Uh, there are no decelerations, ma'am.
So reassuring,
Contractions are also
a good CTG.
reassuring. Yes, ma'am.
And it's on for the induction done with a gel. And a night 3:40, they put a CTG because she started having contractions. Okay.
Yes, ma'am.
PV was not mentioned here. And the baseline is 150. Read the CTG. Sorry.
Baseline 150. Variability is around 10, ma'am. Accelerations are present. And deceleration, there is a late deceleration present, ma'am.
Okay.
Describe the decel a little more in detail.
Deceleration is a late deceleration reaching up to not able to read that mark, ma'am.
That's okay.
That's okay.
What else in that deceleration are you looking for?
Which deceleration you are looking for?
This is a variable deceleration, ma'am.
Okay. So will
And
you call it's a variable decelerations? Okay. Why suddenly you change it to variable deceleration?
I actually didn't notice these two, ma'am. I had zoomed up, ma'am, so I didn't notice the other two decelerations.
Okay.
So one appears to be coinciding with the contraction. One appears like late pattern, ma'am. So it's not consistent with each contraction. So this is a variable deceleration, ma'am. And the variability within the deceleration is present, ma'am. So this is a typical variable deceleration.
Okay. So you are reassured.
Yes, ma'am.
Repetitive and it is coming back to the baseline. So it is only few deceleration. So 150 base. So there is a change of baseline to 150. Are you concerned right now?
No, ma'am.
Why? Because there is a change. Will you stop the CTG?
We'll continue it further, ma'am.
Continue. So there is 10 beats per change. So when will you worried?
If it continues to have decelerations even in the next race, ma'am.
Okay. So next race is here. 4:30. 40 minutes later.
Now there are no contractions being marked, ma'am. But despite that,
Contraction may be missed. The same three contractions.
Why
Were that.
not? It's obvious.
but deceleration has deepened further now, ma'am. It's reaching up to almost 90, 100. And there are repetitive decelerations, ma'am.
So this is one deceleration you're mentioning. This is one. Then this is
Yes, ma'am.
one. So
Yes,
very
ma'am.
decelerations. Then this is one. So you are now really concerned.
Yes, ma'am.
Okay, what do you do?
We can try intrapartum resuscitation for a brief period, ma'am, and continue the trace. In case it still is not picking up, then we need to decide for
We'll do a PV. We'll see the status of progress of labor. If she is 3 centimeter, we won't continue the CTG, right?
Yes, ma'am.
Meters because it's an induced labor. So first and foremost is we'll do the clinical assessment.
Yes, ma'am.
Okay. Then if then we will be tachycardia, we'll say it is a labor related tachycardia. It's a prolonged labor. So every time you have to ask for the vaginal examinations.
Yes, ma'am.
If it is 4 to 5 centimeters or 6 centimeters, then we will be continuing the CTGs as long as clear. Like you have to say there is a mnemonic called mothers. So you have to look for progress of labor.
Yes, ma'am.
Okay. You have to look for meconium. We have to, whenever the bad CTG, whenever we have to look for is a hyperstimulation. M is for mothers, O is for oxytocin. Okay.
Okay, ma'am.
T is for temperatures like fever or
Okay, ma'am.
anything. H is for hyperstimulations. E is for the environment, epidural, and R is for the any risk of scars or anything. Okay.
Okay, ma'am.
So this is how you will be doing it. So is there no other, R is a rapid rate of progress and S is for the scar. Okay, so rate of progress, you have to ask for it.
Yes, ma'am.
Okay, so This is 160 beats per minute. So now really concern there is 20 beats from the beginning of CTGs. It has been increased.
Yes, ma'am.
Okay, so now it is slowly going in for what suspicious is going in for pathological.
Pathological. Yes, ma'am.
Compensator CTGs, you have to resuscitate. If she is 8 centimeter or full dilatations are going to deliver, you deliver her, right?
Yes, ma'am.
This is so even with this CTGs, you see the cord gases, it's normal. Baby is coping like your case. Even with all meconium, the baby's UPGOR is absolutely fine.
Yes, ma'am.
So tachycardia is a one single feature. So you can differentiate whether it is because of the fever or because of the inflammation of the baby or because of the hypoxia. Fine.
Yes, ma'am.
The tachycardia associated with variability, reduced variability or late deceleration only, you will be having concern.
Yes, ma'am.
Okay. So at the end, so will you be waited for some more time for your case or not?
I would have not waited still, ma'am. With
Okay.
grade 3 MSL and CPD.
Hmm. So not even another 2 hours. According to the guidelines, the EPID progress another 2 hours. Madam, verdict, ma'am.
Yeah.
Your verdict.
I think, each one is justified in what you are doing, but a couple of questions. One is CPD a retrospective or prospective diagnosis?
Um, it was actually a retrospective diagnosis only, ma'am.
So you
The
said it's one
pelvis
of the
seemed,
indications. You said it was an indication for your cesarean.
um, the pelvis was adequate, ma'am. Molding was only grade 1. It could have been a physiological molding also, or it could have been indicator of CPD also, ma'am. But the height
Okay.
of the patient was only 149 centimeters,
You
short
knew
stature.
even in the beginning, no? Even without grade 2, then grade 3, she would have still qualified for a cesarean, right?
For cesarean. Yes, ma'am.
Yes.
For her, no, ma'am. I mean, for her, it was not clear cut CPD.
Actually,
Mainly
a
the
term,
grade 3 meconium.
I know the word CPD, the term is something we all use very frequently and loosely, but you have to be careful where you use CPD. That's important. And most of the time, it's a retrospective diagnosis. Because every baby has to go through that pelvis. So it's a question of disproportion for that baby, for that pelvis. So be careful
Yes,
in the
ma'am.
way you use the word.
Is there any
And the
role of
other,
amnio infusion? Ma'am, is there any role of amnio infusion? One question has been asked.
okay. Let our candidate answer first, then we'll tell.
And
Roshni,
there
what
is
is your
there is no role, ma'am.
why?
It's not true to be superior. Like I don't know
Okay.
the details, ma'am, but it's not used, ma'am.
That's
It's
not
not proved to be beneficial.
not conform in any guidelines. There is no proven effect, no large trials, and on the other hand, you run risks of meconium aspiration also for the baby. So you should not actually be doing it. Though it is a common practice to do it, we should not. Right? And one more point I thought I should tell you is familiarize yourself with the both the CTGs. Right?
Okay,
So
ma'am.
don't just stick only to the LCG, because most of you, even your examiners, would probably be more familiar with the
Modified
WHO
pattern.
modified. So, but you should also tell them that you are aware of this, and as Deepa quite rightly pointed out, the same patient, same findings, how it looks on the two partogram, because that will influence your management.
Yes,
Yes,
ma'am.
when you are practicing, when you're learning itself, you try to do both. Then you train your
Yes.
mind to think about the thing. Yeah, I'm fine. Deepa, anything else you want to?
So at the end, Roshni, are you convinced?
About what?
The sum up,
Yes, ma'am.
the summing up is like your CTG reading. Are you satisfied with the CTG? That was a suspicious CTG or normal CTG?
It was a suspicious CTG, ma'am.
Okay. So the reason is tachycardia.
Yes,
Okay.
ma'am.
You could have asked, there is no, since you prepare for the C-sections, you don't have a CTG. So this is a background risk of priming 1 hour leaking with grade 3 meconium with suspicious CTGs. So after CTG itself, you discussed and decided for C-sections. C
Cesarean. Yes, ma'am.
outcome is fine. Okay. So is it any other outcomes, any other follow-up for the previous, next pregnancies for her? Will you allow VBAC for her?
No, ma'am, because it was 5 to 6 centimeters dilatation we have done, ma'am. So, and it was an emergency cesarean section. But it also depends on the interpregnancy interval and her scar thickness on follow-up, ma'am.
All those follow-ups and other things, you have to counsel the patient.
Yes,
Okay.
ma'am.
So you have to more to talk to the patients. Okay. So she's a one more thing, she's a private patient, right?
Yes, ma'am.
So so why she came so late? She had any diminished fetal movement so late in the labor court?
She told she was trying to cope and she was not sure whether it was labor pains, though we had actually advised her to come anytime when she has labor, mom. When like anytime when she has pain or leaking or decreased fetal movements or bleeding, she's supposed to come. But she told she wanted to wait for some time and then come because it was at night time that she had pains. She wanted to wait till morning, and by
Oh,
that time it had increased.
okay. Okay. Thank you. One more question in the chat box. Is there a value of scar thickness in VBAC? Did anyone doing a VBAC routinely doing a scar thickness? I don't do scar
No,
thickness.
ma'am.
I
Okay.
don't do at all, madam. That's why I asked the question. Because, the candidate also mentioned that depends on the scar thickness. I will give VBAC அப்படின்னு அவங்க சொன்னாங்க. அதனால தான் I put the question across. Because the scar thickness is what you're going to see during pregnancy and how she's going to react when the patient is going into labor and how the scar is going to react. It cannot be predicted antenatally at all. So அதனால, because we see when the uterus is quiescent. And how long it is going to take for it to rupture, we don't know. அதனால தான் நான் கேக்குறேன், is anyone deciding based on scar thickness whether it is good னா நாங்க விடுவோம் அப்படின்னு ஏதாவது பண்றோமா? Are we doing? I'm not
Yeah.
doing.
No.
But it's a better practice to have a scar thickness before any labor VBAC, but that's not a one predictor. Even most of the previous LSCS elective section, if you see, there will be no pains, nothing. There will be a
But
scar.
the scar will be so thinned out, papery thin, with artery forces we can still open up.
So it's not really matter whether the contractions causes scar thinness. We really don't. So your fetal monitoring is more important. That shows first. Okay, thank you, Roshni. It's an
Thank
awesome.
you, ma'am.
Next month, IOG is doing presentations. Yet to get the presenter name. So we'll see you on next Tuesday. And thank you, Jayashree ma'am.
Thank you, Deepa. Nice
Thank you.
comparison.
Thank you, ma'am.
Thank you,
Thank
Meena.
you, Jayashree madam and Deepa madam and Roshni. It was an excellent discussion, and those of who have missed the session can see in the YouTube.
Also,
thank
try to attend the next session. Okay. Yeah.
Thank you, madam.
Thank you,
Thank
Chitra.
you.
Thank you, Chitra Kala.
Thank
Thank
you.
you, madam.
Bye.
Bye.
Thank you, ma'am. Thank you.
Yeah.